Make sure. All right, everybody. Sorry we're a little more snug today. We got ousted out of our usual space, so we will filter in more chairs if needed. Again, today is August 20th, 2019, and welcome to the Johns Hopkins Department of Physical Medicine and Rehabilitation Grand Rounds. For those of you attending remotely and who would like to record your attendance and get CME credit, the number to text and the phone number is on the screen right now. So take a few moments to do that if you have not already. If you, for those who, well, you're not going to hear this, but if you arrive late, usually people find me. Anyway, so today our keynote speaker is Dr. Chung. He's a part of our Department of Physical Medicine and Rehabilitation here at Johns Hopkins. He is a neuromuscular medicine specialist, and he is a part of both our POTS program, which he's going to talk about more today, as well as the myositis program here. I guess without further ado, I'll let you start your chat, and hopefully we have no more technical difficulties.
Okay, thank you. All right, so for those who don't know me or not yet met me yet, my name is Chung. I'm a neuromuscular specialist and I run the POTS program. And I guess some of you probably heard about POTS. I see some residents who work with me in my clinic, so they saw some POTS patients. So today I'm going to talk about mainly POTS for sure. And I'm trying to kind of go through all the slides as fast as I can. I think I have a 1.5 hour, but I like to have at least probably 30 minutes or 15 to 30 minutes for kind of discussion. I like this to be a little more interactive. If you have any burning question, you can interrupt me in the middle too, but you can wait until at the end too for further discussion. Nothing to disclose. These are the objectives. Now, if you go to any lecture for POTS, this is probably one of the most common slides you're gonna see. Blind man and elephant. Have you heard about this story before? This is like Hindu, kind of ancient Hindu story where 6 blind men touching the elephant, but these people are blind, so they don't know whether they're touching the elephants or something else. So they're touching different parts of elephant, and there's some guys say, oh, it's a spear because they're touching that, the part of that. It's a snake. They're touching the nose. It's a wall. It's a rope. It's a fan. They're not seeing the big picture. Currently, POTS, current status of POTS is just like that. POTS are, you probably heard about POTS, but you probably didn't learn in the medical school. And it's been, there are not many specialists across the country in the world who sees POTS. And, it's usually either neuromuscular doctor, neurologist, or cardiologist, but sometimes it's allergists, GI doctors, and pediatrician, cardiologists. And we are seeing, from the different background, we are seeing kind of very different aspects of these POTS. We all agree that it's probably the same population, but because we are, neurologists or GI doctors, they are seeing from different angles. It's just like blind men touching different parts of elephant. That's exactly what it is at this point. However, I think the good news is we are touching the elephant now. We're not ignoring the elephant in the room now. And another thing is, although it kind of you probably haven't heard a lot about POTS yet, it's really common, and I bet you've probably seen these patients in your clinic in the past. I assume that most of you guys see patients in the clinic. And imagine this patient who's anxious, kind of younger female, comes into your room in your clinic, right, complaining of pretty much everything in the world. Like they complain of a headache, some kind of myofascial pain everywhere. It's pretty vague, but if you ask them, if you have finger pain, they will probably say yes, they have a finger pain. If you have foot pain or chest pain, they all have it. You just ask them, they have pain everywhere. But most commonly on the upper back and the neck, kind of like coat hanger syndrome, That's probably most common, but of course they have a lot of pain everywhere too. They have like some weird GI symptoms, nausea, vomiting, and also at the same time they're chronically severely fatigued and completely, and maybe depression and anxious. There are some psychological components there too. Well, but at the end of the day, I mean, you ask them like their pain level maybe like 3 or 4 out of 10. Of course, they may say like 20 out of 10. But regardless, they're completely disabled out of proportion. These are the people who used to go to like work and study and like type A student personality, but suddenly they just stop going to work, stop going to school. They're just completely bedridden. So then you order all the tests because you learn in the medical school fatigue, thyroid function, and all that kind of stuff that you know you think is relevant, and everything comes back as normal. So, well, first of all, have you seen these people before? Can you raise your hand? Anybody saw this patient in your clinic? So I guess pretty much everybody who see any patient will probably seen this patient at least once, right? So what's your diagnosis then? If you see these people, you've already seen these people before. How did you label these people? What do you say them? Just can you throw any? I guess like more commonly fibromyalgia. It's a kind of default diagnosis. To be honest, like personally, I'm not trying to cause any controversy or something, but personally, I don't know what fibromyalgia means. I don't think there's any solid biological basis for that diagnosis, but it's a good diagnosis if you don't have any, if you run out of other things to say, it's fibromyalgia, right? It's combinations of pain and some anxiety and stuff like that. Well, and then at the end, like patient walks out of the room, you have your colleague, and then they say like that, right? This is a common jargon we use between doctors. They're probably crazy. It's conversion disorder. It's like psychological manifestation. Physical manifestation of this their psychological problem and so on. Well, I mean, you can easily blame for their psychology and stuff like that. But I mean, at the end of the day, if you already all seen this patient, I just described a little bit of that, but most of you are actually raising your hand saying that you've already seen the patient. So, and it's not just you guys or me. Like if you I've been to some different places for this kind of lecture for cardiologists or primary doctors. They're all raising their hands. So it's possible that it's probably a clinical syndrome, right? Because if they're kind of characteristic, like there are some characteristics that are pretty common. So it could be called as some kind of clinical syndrome, right? And in fact, it has been called in different names in the past, and I'm just going to go through really briefly about that. So there's a thing called neurasthenia. Have you heard about this term before? So it's actually still in the ICD-10 code. So it's actually actual diagnosis. Literally, it's a nerve exhaustion. But I mean, it's a really popular term back in 19th centuries, but people don't use it anymore. George Baird was an American neurologist back in 19th century who was he didn't create this term, but he was very popular and very famous for having this kind of clinic. And if you look at the description, it was actually a description describing it's actually New England Journal of Medicine, but I was quoting a different name. I forgot the name. Boston Surgical Medical Journal or something like that. So he published the case reports of neurasthenia, saying tenderness of scalp, sweating hands, dryness, insomnia, inappropriate phobia, fatigue, and anxiety. It just sounds like exactly the same population we're talking about. He says it is at once the most frequent, most interesting, and most neglected nervous disease of modern times. I guess this is exactly the same too. It's also very neglected. He also called this as a disease of Fifth Avenue. He practiced in New York City, and at that time, even probably now, the Fifth Avenue is a really affluent part of the city. And he sees all these patients, younger female from wealthy, affluent family, comes in and saying like, oh, I just can't do anything. So he calls this as a disease of Fifth Avenue. He also thought that this is actually more common in industrialized world. So he also coined the term Americanitis. So you see it in kind of nice, wealthy European countries in America at the time, so kind of Americanitis. He didn't know anything about that. It kind of sounds like also some psychological, psychosocial factors there too. So was it considered to be psychological at the time? Well, our famous Sigmund Freud actually didn't think so. He was actually very interested in neurasthenia. In fact, Sigmund Freud was actually a neurologist, neuropathologist, before he became psychologist. And at the time, he as a neurologist, it's kind of a modern version of selective rotation. So he was in Austria, but he went to the famous French hospital, Salpêtrière Hospital, where Jean-Marie Charcot was practicing. And you probably heard the story. Like he's a famous Dr. Charcot was a very famous neurologist, and he was doing hypnosis. He used a lot of hypnotic techniques to put them to sleep. And that time in the European countries in 19th century was like, booming in economy. So there was a lot of like railroad construction, and a lot of people got injured and has an increasing number of insurance claims. And all this patient comes in with a paralyzed arm, and as a doctor, your job is to figure out this is a real or actual nerve disease or nerve injury. And imagine 19th century, there's no MRI, there's no X-ray, there's nothing. So you have to rely completely on your really good neurological exam. So Dr. Charcot tried to show that there's actually something called conversion disorder, so physical manifestation of psychological disturbance. He put them under hypnosis and completely get rid of the symptoms. These people, Dr. Charcot showed that like under hypnosis, some patients, they're paralyzed, but then now under hypnosis, they're walking around. So kind of proving that this is a psychological problem. However, Dr. Freud was actually also very interested in neurasthenia at the time, and he made clear distinction between hysteria and neurasthenia, saying that neurasthenia is actually actual physiological neurological problem that they have a lot of GI problem, headache, whereas hysteria or anxiety neurosis is more psychological in a sense that under the hypnosis their symptoms can go away too. So it's actually really not quite psychological. And if he was interested in neurasthenia, study more. Unfortunately, he didn't do it, so he didn't really discover POTS, but he, literally founded, the field of psychology afterwards. And moving on to early 20th century, another name is called Da Costa syndrome, or also known as soldier's heart. And Da Costa was also American physician. And after American Civil War, he found that a lot of soldiers developed this anxiety, palpitation, orthostatic intolerance, and severe fatigue, kind of same population, often develop after a bout of fever or diarrhea. So it's kind of very similar to Guillain-Barré syndrome or something, which I think is a kind of interesting observation at the time. However, he reported that there's a lot more men than women, which is slightly different from kind of population that we see. I guess that's probably because first he studied more in the soldier population. It's a little bit biased, and also some of the symptoms, the anxiety and palpitation, kind of sounds like PTSD too. And even in POTS, there's some kind of talks about some relation between PTSD, some traumatic events between POTS as well. And Stacy's here, but Dr. Soskow's here. And there's some link between some pediatric kind of concussion, mild concussion to autonomic dysfunction and POTS as well. So maybe there's a little bit of this connection there too. Now, skip all the way to 20th century. So that's actually modern version of this, whatever the syndrome you call, it's going to be POTS. It's coined by Dr. Philip Lowe at Mayo Clinic in 1993. He still practices. So it's relatively pretty recent thing. So these people, the same population we talked about, like anxious female, like chronically disabled, fatigue, orthostatic intolerance and everything, he brought these patients to, it's called tilt table test. Are you familiar with this? So basically it's literally a table that tilts up to 70 degrees. And these people, we actually now have a tilt table test in the Green Springs. So if you want to actually try it yourself, you can. It's actually, if you don't have POTS, it's one of the most boring tests you're ever going to get. You're just going to lie in the table and tilts up for 70 degrees for about 10-15 minutes, that's all. And it's really boring and nothing to do. And they're checking their vital signs. But for POTS patients, interestingly, if they put those POTS patients on the tilt table test and just bring that up to 70 degrees, most of them will have severe dramatic reproduction of their symptoms. They feel they're gonna just die. A lot of them just puke, and their heart rate goes. So by definition, it's more than 30 BPM increase within 10 minutes, or 40 BPM increase for pediatric patients, or even though it's less than 30 BPM, if it is more than at one point, if they develop heart rate more than 120, it's by definition postural tachycardia. Now, not only that, usually they have a dramatic reproduction of symptoms. They just all go crazy. Oftentimes they have to just stop the test right in the middle. And usually we'll see their like baseline heart rate being like 70s and 80s, and then just dramatically go up to 150 right away. And they all like feel like they're gonna pass out. They don't usually pass out. They almost feel like they're gonna pass out. However, so this is actually one of the first things, something that's suggestive of a physiological etiology of this whole craziness, right? It's not a cardiac condition. You have to prove that their heart function is normal. So it's kind of suggests that there's some kind of neural control problem in their circulation. So now we get to the point. Before that, a little bit of clarification and definition. When I say postural tachycardia, this is description of T table test. So anything that meets the criteria for more than 30 BPM and everything is postural tachycardia. But when I say POTS as a clinical syndrome, I'm talking about is the whole population that presents with chronic fatigue, anxiety, palpitation, GI problem, and everything as a clinical syndrome, not necessarily postural tachycardia. And in fact, patient with POTS as a clinical syndrome, on the T table test, they may show actually dropping blood pressure, which is newly mediated hypertension. It can be even hypertension, like young 20 or even 15-year-old patient, they can develop like shooting of blood pressure, which is another subtype called hyperadrenergic type of POTS. And it can be just normal response too, but usually they do have reproduction of symptoms, but their vital sign response can be various too. Now, when I said that, it's a little bit controversial because it was still, when I recently went to an NIH workshop for POTS, and there was a bunch of doctors who really see POTS patients, and this is actually probably like half of the people in the room will probably kind of agree with me in that POTS is a clinical syndrome. They don't have to show the tachycardia, whereas some cardiologists they will probably say, well, you have to see tachycardia to call this as POTS, although even those cardiologists will probably agree that even if you don't see tachycardia, if you put them on a T table test next time, at some point you're definitely going to see the tachycardia anyway. So they all agree that these are the same population. We just have a hard time labeling this population at this time. Some people may just call this a chronic fatigue syndrome, like Dr. Peter Rowe. But again, this is an ongoing process, but just for the sake of this talk, I'm just going to talk about POTS as a clinical syndrome, encapsulating all this population, literally this patient you're seeing all the time. Now, how do you explain all this stuff then, right? Now we kind of got to the point. Now we are talking about like maybe psychological, physiological. Now we are talking about maybe there's a little bit of physiological stuff there too, like T table test response is something that you can't just fake. So how do you explain that? Now, before we go there, let's just look at a little more detailed clinical features of POTS. This is a very typical presentation of POTS. Usually starts in late teens and early 20s. I think median is probably between 15 to 20 years old. Actually, just about half or a little bit more than half of these people will start their symptom very sudden onset. Within they're just usually very normal, not only normal actually, I have kind of theory, but they're usually like really good student, like OA student. They're very active, athletic, and OA kind of student. And suddenly, they just can't just get up and go to the school. It's pretty dramatic. It develops over like days and weeks. And a lot of my patients actually can remember exact date they just stop functioning. That's how dramatic they can be. And if you really ask them further, just about like 50 to 60% of patients will say, well, I actually had some kind of virus illness, some diarrhea, or some kind of infection just about a couple of months before they present with this whole kind of craziness. It's severe, profound fatigue. That's actually the most debilitating symptoms. And orthostatic intolerance. Whenever they get up, they get dizzy and lightheaded, and that's very debilitating. They also have a chronic muscle pain and headache. Kind of muscle pain. There are different kinds of muscle pain, but kind of muscle pain, I call you guys know like what DOMS means, right? Delayed onset muscle soreness. You probably experienced it. You go to gym, Like I didn't go to gym for a couple of weeks, so because I was sick and I have a lot of excuses. And if I go to gym to catch up, like 5 hours, I'm probably gonna have a lot of pain. And this kind of pain is called as DOMS, right? Delayed onset muscle soreness, which is a physiological phenomenon. Everybody has it. But these people, even without going to the gym, they just do some chores or things that they do all the time. They just have all this DOMS-like pain. They have like severe cramps everywhere. That's kind of muscle pain that's debilitating. Oftentimes they have a severe nausea, vomiting, or lack of appetite. Their digestion slows down. They just can't do it, and they have like kind of IBS, alternating constipation and diarrhea as well. And overall, if you really ask them, their course actually fluctuates quite a bit over time. So they start in like late teens, and they are kind of debilitated. But then in the early 20s, somehow they just kind of grew out of it. So they go back to school, they kind of work, not to the baseline normal, but they kind of function enough, but then like mid-20s or 30s, they have another flare, and they just drop out, and they kind of fluctuates over lifespan. So how do you explain that physiologically? So kind of working hypothesis at this point, and what a lot of people think is probably it's a fail to supply blood circulation. It's actually a blood circulation problem. So for example, for the muscle, like if you try to do like DOMS-like pain, imagine if you're trying to kind of work out and use your muscle, and your blood can't really send circulation adequately, you're gonna have a lot of muscle pain for sure. It's kind of like lactic acid buildup because there's no circulation. However, at the same time, if you do an EMG, if you examine their muscle and nerve are fine. That's normal. That's the kind of the lab test that you're going to do immediately, right? Their CK level is normal, EMG is normal. So by default, you're going to say, oh, it's all crazy. But you didn't look at the circulation. There's no good clinical tools to look at the circulation. Oftentimes they complain lack of concentration and brain fog. They say this is kind of foggy feeling, they really can't think right, and they have some kind of memory problem. And also, presumably, there's a kind of lack of circulation there. And there's actually some evidence using the cranial Doppler, when they have this brain fog, there's actually reduced circulation there too. Also, chronically, they do have orthostatic intolerance, chronic fatigue, because they have a reduced preload, because from the lower part of the body, they can squeeze all the blood circulation back to their heart. So of course, you have a reduced preload, you're gonna be very tired, right? So those explain some of the symptoms, so I call this pump failure. So basically what happens is the blood pump is not working, and that pump is not really supporting the metabolic needs of each tissues to send sending all the circulations. So what happens is so imagine this is blood vessels in the picture, and basically it's we call this vasomotor innervation. Basically, that nerve fiber kind of wraps around arterioles, blood vessels, and whenever you need some blood, you know what happens, right? Kind of constrict or dilate blood vessel in a way that it kind of pumps blood to the target tissue, and that specific fiber, the yellow stuff, actually comes from sympathetic nervous system. And that's actually what happens if you activate sympathetic nervous system, right? It's a fight or flight reaction. So imagine some bad guy is chasing after you. What happens? You get anxious and everything, but your muscle get tensed up and you have to run away. It's a flight reaction, right? Fight or flight. So you need more blood pumping into the muscle. That's how that happens. So imagine that pump is not working, the POTS patient. It's somehow denervated. You're not pumping the blood. That's why you get all these symptoms of so-called pump failure. However, that's not the only thing that's happening in this population. Their baroreceptor function is normal, and you guys all know what baroreceptor reflex is. Basically, simply speaking, this is basically a pressure gauge in your body. Because in your body, blood pressure maintenance is very critical for your survival, right? So body has all these mechanisms to maintain your blood pressure. So in aorta, there's a couple of like chemoreceptors and pressure receptors. So if you have like reduced pressure or preload coming back from the lower part of your body, it activates this baroreflex loop. And what happens is that it directly connects to your brain. And then, let's say if there's a drop in your blood pressure or reduced pre-cardiac load, what happens is that through this reflex arc, your brain activates your sympathetic nervous system very strongly, right? And then what happens is that it causes tachycardia, right? So it's a kind of natural response, compensatory response to kind of survive, right? So if you have like reduced preload to your heart, what happens is that you have to beat fast to compensate for it, right? So that's actually why you get the tachycardia when you bleed or have some dehydration and stuff like that, right? So in POTS patients, because there's a really reduced precardiac load, their baroreceptor function is completely activated. It's kind of hyperactivated. So they release a lot of sympathetic neurotransmitters, such as like adrenaline. So they have kind of adrenaline surge symptoms that can be also debilitating too. So for example, so what happens is that not only they have these pump failure symptoms, muscle pain, orthostatic intolerance, chronic fatigue, and migraine, now they're, through the baroreflex function, they actually increase their sympathetic nervous system, and that causes a lot of symptoms too. So when they activate the sympathetic nervous system, well, of course, they cause tachycardia to compensate for this kind of lack of circulation. But what also happens is that they get anxious, and if you're anxious, you're not going to sleep. It causes insomnia, and it kind of under fight or flight reaction, under sympathetic nervous system, you're not supposed to digest food. It kind of slows down your GI tract, so it kind of predisposes nausea, vomiting, and altered kind of bacteria, gut bacterium, predisposing SIBO or irritable bowel syndrome, and also often causes a lot of nausea, vomiting. And also you have a lot of hyperhidrosis, meaning a lot of sweating at the same time. So basically they experience a lot of adrenaline surge too at the same time, and that can be very debilitating and uncomfortable too. So what I usually do, just for the practical purposes, I actually kind of classify all the symptoms in two categories, and one of which is pump failure, and the other is sympathetic overcompensation. And like I explained, pump failure symptoms are basically chronic fatigue, orthostatic intolerance, dizziness, migraine, and muscle pain, all that kind of stuff. Lack of circulation problem. And the other thing is sympathetic overcompensation, which is usually anxiety, nausea, vomiting, palpitation, and sleep disturbance, and all this other kind of stuff too. Now, if you think about it, these are actually kind of completely opposite end of the problem. This is actually basically sympathetic dysfunction, but in the one arm, which is pump failure, I told you there's some suspicion that there's a sympathetic denervation going on, right? But at the same time, there's a sympathetic overcompensation. So this is actually kind of paradoxical in a sense that they have a lot of too much sympathetic symptoms, but at the same time, they suffer from lack of sympathetic function. And that actually has a lot of implication in the treatment too, because if you use some medication to treat sympathetic overcompensation, that actually can worsen pump failure symptoms and vice versa too. And that's actually what makes this treatment kind of a little tricky. Now, before you go back to the treatment, okay, so just to summarize, because as a neuromuscular doctor, my job is to usually try to neurologically localize the problem. And now we said that, well, there's a probably peripheral sympathetic dysfunction, denervation, probably vasomotor denervation that fails to regulate the circulation. At the same time, their central baroreceptor reflex function is normal and intact. Not only that, it's actually hyperactivated. So we can probably localize to peripheral sympathetic area, and with all the other reasons that I can tell you a little later, probably because if you imagine, like, you probably all maybe closer to my medical school, so you probably remember the neuroanatomy. Do you know where the sympathetic nervous system is located? The answer is already in the slide, right? The thoracolumbar segment is called sympathetic chain ganglia. So interestingly, there's actually a lot of evolutionary kind of reason for that, but our sympathetic nervous system is clustered in the thoracolumbar segment right next to the spinal cord and ventral root. It actually forms chains of these neuronal cell bodies, and this is actually the whole sympathetic nervous system axons coming out of. And it's only in the thoracolumbar segment, whereas the parasympathetic system is all spread out everywhere, and the neuronal cell bodies in their tissues is kind of hard to find. But sympathetic nervous system is all clustered at the same place in the thoracolumbar as a sympathetic chain ganglia. But like I said, their baroreflex function is normal. That kind of suggests that their central nervous system is normal. So it's probably peripheral nervous system problem, not the central nervous system problem, right? So what is the evidence? Do I have an evidence to say that? Not much. Just a little bit, okay? I'm admitting that. Like nobody actually has. So I'm actually really honest. So when I come to see my patient, I say that, okay, well, if you see 10 POTS doctors in the country, you're gonna get 10 different versions of explanation. But at this point, nobody actually has a really solid good science to say that, oh, I'm right and everybody's wrong. This is actually, oh, again, I'm one of the blind men here. Okay, so as a blind man and neuromuscular blind man, some of the evidence is based on more clinical behavior so far and my experience, but some of the actual evidence suggests that this is probably the case. First of all, QSART is called quantitative pseudomotor axon reflex test. So just simply, this is actually a pretty simple test. Our sweat gland is innervated by sympathetic nervous system. And I'm going to show you in the next picture, but basically our sweat gland kind of looks like a little pocket, and the pocket contains a lot of water, which is sweat. And then when you activate your sympathetic nervous system, it squeezes the pocket and produces the sweat. Okay? So simply, and this sympathetic nervous system, for the sweat gland, the neurotransmitter is actually acetylcholine. So this test is pretty simple. It basically produces, releases acetylcholine on the skin, and stimulates the nerve and then produce the sweat. So, and then measures the amount of sweat production. If you can see, there's a time and amount on the y-axis. So you can actually check how much of sweating comes out per stimulation. The great thing about this test is that it actually has a normal standardized. So you can compare that with the age-sex matched population and see how much you're far away from it and too much of it and so on. And in POTS patient, it's been well known since actually early 1990s. Actually, there's one of the first Dr. Philip Lowe's New England Journal of Medicine publication showing that these patients actually have a flat response for QSAR, meaning they don't produce sweat, which is kind of a little weird because I told you that they have a lot of sweating, but then if you test that, you don't have any sweat. Now, it's paradoxical, right? And when the sympathetic denervation comes out, again, this comes directly from sympathetic chain ganglia, but from the same branch, it's not only the sweat, it branches out to the blood vessels, and it also innervates the blood vessels. So by showing the reduced innervation to sweat gland, we can kind of imagine that there's a reduced vasomotor innervation as well. Now, just evaluating directly the vasomotor innervation directly from blood vessel is kind of very technical, so there's no technique we can do. We're kind of trying to develop it at this point, but there's no really known standardized method of doing that. So that's actually relatively simple because you can just test that right away. Another piece of evidence kind of as related to that is a skin biopsy. You probably heard about this. We do this punch skin biopsy, take a small piece of skin, and we stain the nerve under the skin. And we do see mainly a couple of things, but mainly small fiber density and also sweat gland innervation too. And Hopkins is actually one of the few skin labs that quantify the innervation of sweat gland innervation. And in the lower hand, the picture is that the black stuff is all this small fiber that's wrapping around the sweat glands. Actually, that axons are basically a sympathetic nervous system, right? And there's actually a method, Dr. Polizevskis and this team, Justin McArthur and everybody developed in the past to quantify this sweat gland innervation. And I do have a preliminary data that's not been published yet, but we actually compared POTS patient and control, although they kind of, oftentimes they're reported as a normal, and by normal, we define as more than lower fifth percentile from our own kind of value. But if they look at it, there's actually a significant difference between age-sex matched population in terms of innervation of sweat gland. So taking this together, there's actually a functional deficit of sweat gland innervation, and there's actually also pathological proof that there's a reduced innervation, which in turn suggests reduced vasomotor innervation, right? So that's the evidence I have so far. The last piece of evidence I actually didn't put in the slide is that actually autopsy results. So Disorder International, I work with a lot. There's a big patient foundation. They actually started this autopsy study. And so far, there's an N of 1, so I didn't want to put this in the slide. But so far, what I heard from these people is that they actually autopsy this person, POTS patient who died from unrelated disease. She's only like 20-something years old. And there's a tons of inflammation around the sympathetic and ventral dorsal ganglia there too. So maybe that's a piece of evidence that's suggesting towards to this sympathetic denervation theory. Okay, so that's all the evidence. It's pretty short. So then what is the mechanism? Like how, okay, well, if that's the case, like why do they get it? Why do they have this problem? Also, there's a lot of theories surrounding, okay, well, could it be autoimmune problem? I think actually it's autoimmune because first of all, usually they have a lot of some infection before the onset of the symptoms. As in a lot of other autoimmune conditions like Guillain-Barré syndrome, we know that there's a Campylobacter infection followed by all the onset of the symptoms, and and also their course fluctuates and all that kind of stuff. I kind of talk a little more about the autoimmunity, but I feel like there's autoimmunity there. There's a group of people who think it's all genetic, and actually, in fact, a lot of my patients have a very extensive family history. A lot of people, when you ask them, their mom probably had it, probably to a milder degree. Their siblings have it. So there's actually strong family history there. So that kind of suggests probably some genetic predisposition, or maybe it's a genetic condition. Of course, always, as with any disease, always the answer is genetic predisposition and autoimmunity, interaction with the gene and environment. That's always the answer, right? So you can't go wrong with that. And also another thing is actually IVIG probably helps. And I have a very small number of patients. As you probably know, IVIG, especially at a higher dose, it's an immunomodulating therapy. It kind of precipitates all those bad autoantibodies. That's how kind of people think it works. And with the IVIG, sometimes it can be dramatic. So you can get like complete wipe out of the symptoms of these parts. And I have some patients who just almost became normal with IVIG. So just between you and me, don't tell your patients about it, because you're going to get into trouble. So another thing that I kind of want to mention, that there's a lot of overlapping syndromes too. And when you see this patient as a past medical history, these are the things that you commonly encounter. And not only these 4 I listed, there are so many other things that I probably didn't think are worth actually putting in. But I'm just going to talk about two things: mast cell activation syndrome and EDS. And other things are a little bit kind of minor. Mast activation syndrome, have you heard about it by any chance? So it's an overlapping syndrome. So if you actually, again, like I went around and actually ask a lot of people now. So I actually did go to a lot of allergists at Hopkins. If you ask 10 allergists at Hopkins, well, probably 6 or 7 will probably say that's all BS. It's like fibromyalgia, like it doesn't exist. Some people will believe there's such a thing there. And for those but I'm not an allergist. I don't have any real educated opinions about this, but this is actually a common phenomenon that I see all the time in the POTS patients. So basically, it's basically some allergy. So if you see those people and you look at under allergy, you see probably 50 different allergens there, which doesn't make any sense. And if you really ask the allergist, true allergy, I mean statistically speaking, the statistical chance of having any real allergies to more than 3 or 4 allergens it's almost like striking, getting thunder 3 times in a row or something like that. It's just it's very rare. So if you see anybody who's listing allergies more than 5, that's just really not actual allergies, right? But these people actually, interestingly, have kind of allergy-like syndromes. So they come with this kind of phenomenon where, they're taking this medication for years, and then suddenly they just break out all the rash and swelling everywhere, just like true allergies, and then they stop it, and then maybe years later they resume it, they're not going to have any problem. Same as the foods. So it's not a true allergy in a sense that it's not specific to one allergen, but they have all these random allergy-like symptoms, like it can be asthma, and swelling and rash everywhere. And the theory behind that is that, you know what the mast cells are, right? So basically mast cells are the cells that's kind of residing in the different tissues. And in the true allergic reaction, when there's an allergen and antibody binds, and that stimulates mast cells, and mast cells have a lot of granules there, and granules contain all the chemicals that causes all the allergy-like symptoms. These are the chemicals that causes the hives and swelling and rashes and everything. So mast cells are the cells that are kind of effector cells for allergic reactions. And there's a theory that these mast cells are unstable, and without having true antibody antigen or allergic reaction, they can be stimulated and then burst open all these granules. And that's the theory behind mast cell activation syndrome. And it's common phenomenon that a lot of POTS patients will complain, and this is again without any evidence. My own view is that there's actually mast cells actually can be stimulated by catecholamines, like the sympathetic neurotransmitters. So I wonder if because POTS patients have hyperactivated sympathetic nervous system, they release a lot of adrenalines. I wonder if that's stimulating mast cells and causing these symptoms. So there's a lot of unknown things about this mast cell activation syndrome, but it's pretty common that you're going to encounter. Another thing that you probably see is Ehlers-Danlos syndrome, and among the different types of EDS, and EDS type 1 and 2, their genotype and phenotypes are really well known. They have a really gene and biological mechanism that's found. But when you say EDS type 3, another known is also known as joint hypermobility syndrome or type 3, it's basically diagnosed purely based on clinical phenotype being hypermobile joints. So if anybody has like fair skin and hypermobile joints without any other things, that's just by definition the EDS type 3. And there's no genes associated with, no biomarkers associated with at this point. But again, like if I see POTS patient, probably 70-80% of people, even without having formal diagnosis of EDS, they are flexible in their joints. So they have like double jointed and everything. Actually, there's a criteria called Biden scale. So like, if more than 90 degrees in their pinky fingers and can touch their thumb to the forearm and all that kind of stuff, there's a score. Currently, like if they have a 5 out of 9 score, it's definition EDS. But again, this is just a phenotype. So because of that, some people think it's probably genetic, but I think it's more like genetic predisposition. I mean, like if you see 10 people with the EDS type 3, which probably suggests that their connective tissues are kind of loose. But like you can also imagine, there's an analogy that I give to my patients, is that you can imagine like kind of water balloon, and that's attached to the pump. To me, POTS is a pump failure, so that's not squeezing the balloon effectively, right? But if you have this rubber that's really stretchy, you're more predisposed to have this type of problem. So I don't think this is a causal relationship, but this is a kind of problem that they have. I mean, if they have this EDS kind of loose connective tissue, their symptoms are more exaggerated and more severe. But these two syndromes are most commonly encountered syndrome, overlapping syndrome with the POTS. So I have to kind of mention that now. Briefly talk on the treatment strategy. So basically, I treat them, but people have a little bit different approaches. But again, at the end of the day, I'll probably say POTS, if you ask me about POTS, it's a sympathetic denervation causing effective hypovolemia with a secondary sympathetic overcompensation. Is it simple enough? Anyway, so that's so that's POTS. So how do I treat that? Just briefly speaking, I kind of try to treat differently for the pump failure symptoms and sympathetic overcompensation, because again, these are completely two different things, opposite kind of direction. For the pump failure, basically you're imagining this water balloon that's attached to the pump. So if you're not fixing the pump, what you're going to do is filling the balloon with the water and expand the balloon. So as the balloon expands, it's going to build up pressure, and we're going to use that pressure as a pump. So that's, and in fact, I think one of the actually most, when other doctors kind of treat POTS, I mean, including myself too, pump, actually the volume expansion works, but it's just not that easy. We're not rehydrating these people. They're not dehydrated. We're actually expanding the balloon. So, and these are human, not balloons. So it actually takes a lot of water to do that. I usually oftentimes just 4 liters of water and 5 grams of sodium. Can you imagine how much it is? I mean, how much water do you drink a day? I mean, this is like, I've tried it myself, so I can tell you, this is just crazy. It's a lot of water. And even with this amount of water, like you have a GI system, there's a kidney that's pumping out the water. So, like it's not maintaining quite for a long time. Like actually, even with the 1 gallon water, there's a little tiny fraction of water that's staying inside of the balloon. So I'm kind of liberal about this IV saline infusion. I just come give IV infusion like 2 to 3 times a week. Even if I give 1 bag of saline, over a couple of hours, the water, like only 20% stays effective in the effective volume, and that volume stays only about 12 hours to 14 hours from, if you look at the ICU book and stuff like that, it just pumps out right away, which is why you have to give a little more frequent IV saline infusion. However, most people will probably say after just a bolus of saline, I mean, these are the people who've been through like Mayo Clinic or Harvard, Hopkins, you just name it for 10 years, and just one bolus of normal saline, they feel like pretty normal for just a few hours. So that's how dramatic it can be just with the normal saline infusion. However, I'm not going to put them on normal saline infusion 3 times a week forever for the rest of your life. So the next step of treatment is actually physical exercise, and to bridge that, I just give saline infusion, and I use like midodrine and fluorine to enhance their volume expansion. But the goal is actually physical exercise, and how physical exercise works, theoretically speaking. Now, I told you about the pump and pump failure, pump being the sympathetic nervous system. Now, there's another pump, it's a skeletal muscle pump. So it's your legs, calf muscle. It's not just calf muscle, actually, like a lot of other muscles too. But these lower extremity muscles have no valve. I mean, there's a valve there. So if you squeeze it, it kind of brings back blood back to your heart. Now, this skeletal muscle pump is actually really powerful, much more powerful than you think. In fact, like normal person beats, like normal cardiac output is just about a gallon of blood per minute. We pumps out about a gallon of blood per minute on resting. If you start running and jogging around, it goes up to 5 gallons. And some trained athlete can be even more than that. So, and that's mostly from skeletal muscle pump, right? So imagine POTS patient can do that level of, cardiovascular exercise. They're getting like probably 4 or 5 times more blood back to their heart. They feel much better. And I do have a very few patients actually who actually follow through the exercise protocol, and they're all saying it's kind of interesting. They usually say they have to do exercise to gain more energy. So if you guys do exercise, you exhaust your calories and everything, right? You get a little fatigue. But for POTS patient, they get fatigue from the exercise, but the energy they get from the exercise is much greater than energy they lose from the exercise, that they have to do exercise to maintain their function, which is kind of interesting. But I told you they have an exercise intolerance. They try to exercise, they can't pump the blood to the muscle. So they have a lot of setback and crash before they get there, which is kind of what's tricky about the exercise program. And that's kind of my, I have a POTS clinical program now. So that's kind of the key for I work with a lot of physical therapists, and that's kind of the key. Like how can we increase their cardiovascular resistance without causing a lot of crash? That's the main question that I have. And it's been kind of working okay, but a lot of still patients have a hard time tolerating the exercise. Now, I didn't talk much about the sympathetic overactivity symptoms. Now, this is kind of relatively easy because you can use a lot of sympatholytic medications, which is pretty easy. However, you have to be cautious because, so for example, if you look at the POTS and textbook will say, oh, you have to prescribe them beta blockers. Oftentimes, beta blockers, even at the low dose, it can worsen their fatigue or so-called pump failure symptoms. They get the beta blocker, they just can't even get out of the bed. So you have to be really careful, and they have to kind of, carefully, make sure what's main presenting debilitating symptoms are. For now, actually, Marino has been my favorite drug. You don't laugh at me. I guess the rehab population, you're familiar with the Marino, it's basically synthetic cannabinoids. My working hypothesis why Marino works is that it probably enhances some parasympathetic system that kind of offset this sympathetic overdrive. That's kind of my own kind of view on why Marino works. But regardless, it works magic, especially for those who have severe nausea, vomiting, and lack of appetite. I have a patient who's on a G-tube and went to all the GI doctors at Hopkins, tried all the known GI medication in ward, but Marino is the only thing that keeps her from vomiting. So Marino can be really powerful. It can kind of work for generally other sympathetic symptoms for sleeping and a little bit of anxiety too. So Marino works fine. Mestinon, it basically works on, this Mestinon is basically medication developed for myasthenia gravis. It works at the neuromuscular junction. It's a cholinergic receptor. And Mestinon, because if you use Mestinon, they have a lot of cholinergic symptoms. A lot of secretion happening. They go to bathroom a lot. So people with the POTS usually don't tolerate the side effects that well. So it's not my favorite medication, but when it works the magic too. And that kind of suggests that that sympathetic ganglion problem could be problem underlying pathophysiology of POTS too. Meditation and mindfulness, I'm actually increasingly aware that psychological intervention is critical, especially with managing their sympathetic activation, because I feel like this is the more central sympathetic activation. So, I work with Shira Zohar, who was very interested in POTS, and she a lot of people actually use this called mindfulness technique, which I understand as some westernized version of meditation, and it really works pretty well. I have a patient who swears that this mindfulness meditation is way better than beta blocker or Marino or anything that she tried. Of course, just like exercise, they have a hard time actually following it through, but it can be really powerful. The thing is that a lot of people, when I say psychologists, they will just run away because oftentimes, same story, like people will say, oh, this is a psychological problem. They think this is kind of like, they think that I think they're crazy. So, but if they understand this, like I understand that they are not crazy, actually they really want to see psychologists. They are very desperate for that. So we're almost ending the slides, but so why PM&R? As you can see, first of all, it's a very debilitating condition. I have a lot of patients who are just completely bedridden. I mean, I see a lot of other neuromuscular conditions, like myositis, even ALS, and even compared to these people, they're so much more debilitated. I mean, myositis or stroke patient, they can still do certain things. POTS patient, think about it. If you can't get up and stand up, like what are the things you can do? There are not many things you can do without being able to stand up and tolerating sitting up and doing stuff. So it's completely debilitating. A lot of my patients are just completely bedridden. Multidisciplinary approaches, right? Like you have to work with the PTs, cardiologists, and everything is by nature is a PM&R. And usually the main treatments really is exercise and dietary lifestyle modification. So this is like what we do all the time. And most importantly, at this point, no specialists claim this as their disease, right? I mean, cardiologists, it's not a heart condition, so they don't want to see them. For some weird reason, I don't know, but neurologists just don't like this. So when they don't like it, we just have to take it, I guess. And so, I think this is a good opportunity for a lot of PM&R doctors. And, because think about it, like what are our diseases? Like spinal cord injury, stroke probably is actually more neurology at this point. We're just kind of following as a PT or whatever. But I'm sorry about that. But like it's diagnosed primarily by neurologists, right? But I feel like this is a new opportunity for PM&R doctor. I'm sorry about the stroke, but I made a mistake. But what I'm trying to say is this is new opportunity, and also to be honest, I mean this is really even financially makes sense that PM&R doctors seeing patients. I mean pediatricians, it takes too much time to see each patient. They really don't want to see these people. So that's actually why we are getting a lot of support from other departments as well, building up this POTS program. And again, like I feel like this is a great opportunity. And in the future, I'm hoping that there are a lot more PM&R doctors are taking care of this POTS patients. So the summary is probably more common than we thought. Again, to me, it's a sympathetic dysfunction, maybe autoimmune nature. Lyme, there's another discussion. And also treatment requires a long-term multidisciplinary approach, probably fit for PM&R doctors. Now back to the first slides, right? Blind man and the elephant. So I told you, okay, well, I think I'm a very optimistic person. So our future, I think, is bright. Now we are touching the elephant. However, what we're going to do is we just need a lot of collaboration, right? So if you have a 6 blind men, we just have probably more blind men as a neurologist, more cardiologists, more whatever, pediatrics or allergists, everything. So think about it. If there's like 6,000 blind men touching the elephant, now there will probably high chance of detecting this is the elephant, right, instead of 6 people. That's how I see it. So we just need more people getting into the field. And I mean, actually, it's probably more important that these people should be from different departments, different special, different backgrounds. And I actually showed the same slide to cardiologists, and they thought there are too many cardiologists in the picture. but regardless, this is my end of the slide. So yeah, I think it really applies to the POTS. Medicine is a science of uncertainty, not of probability. So any questions? Thank you.
How do your patients tend to do after they come to your clinic and start receiving treatment? So is there some proportion of them that actually can maintain the volume expansion and tolerate medicines and doing well, or do they tend to struggle a lot in relapse?
So I don't know. I could be biased. I think they are doing better than when they first came in. Of course, they do have a lot of relapse and flares, and that's probably because their underlying pathophysiology being course fluctuating quite a bit. I recently asked actually same question. So my clinic, I'm very aggressive about the volume expansion, and also I don't usually start exercise right away because they have a lot of crash. But at some point, if I'm sure that they're drinking a lot of water and getting all the volumes, then that's when I send them to physical therapy. And I recently asked the same question to PT. They'll probably say most people actually, just about like 70 to 80% of people will follow their exercise protocol and they get actually better. Now, I never had POTS myself, and it feels like it's quote unquote, it's just crabby feeling every day. So even though, so the benefit of actually following them in the PT is that we have some objective measures. When they first came in, they can't even sit up, and then now they're doing like walking around for a few blocks. So they may still feel crap, and they feel like they're not going anywhere. But if you actually look back, even those people who feel like they're flaring, not going anywhere, they actually have some kind of more measurable improvement in their PT. So, I mean, and also that more correlates with the volume expansion. The more volume they get, the more activity they have and more functional function they get. So they do respond to, they actually really respond pretty well to the treatment, and actually it's probably better than I initially imagined. Yeah.
And then the demographic that you have coming to your clinic, does it still follow that historical trend of being mostly young women who are affluent, or are you seeing a broader range of patients?
Well, I'm not sure about the socioeconomic status of that. Like, I'm not sure if they're affluent or not, to be honest. But demographic-wise, age and sex, 90% young female, for sure. And that's the same with other clinics that when I asked them. And somehow it's predominantly Caucasian at this point, but I'm not sure if this is just kind of biased or misrepresented or something like that. I think there are probably a lot more in other, ethnicities, but it's just, I don't know, but it's the same in other clinics too. It's possible, especially with the EDS phenotype, fair skin and flexible joints, is it possible that Caucasians have more POTS? That's kind of question at this point. Great.
Very interesting talk. What is the status of their muscles?
So their muscles are actually completely normal. A couple of things though. So actually one of the reasons that the reason that I started my POTS clinic is actually I still have a myositis clinic, right? And these people have a lot of muscle complaints, and that's actually why they came to my clinic. And oftentimes they come with some kind of like probably a single or few episodes of rhabdomyolysis, which is normal. Anybody who's doing a vigorous exercise without adequately drinking hydration, they can develop rhabdomyolysis. Of course, if you have like series of rhabdomyolysis in your lifetime, more than like 5 or 10, they could suggest some mitochondrial pathology or something. But like you can have a couple of rhabdomyolysis, and then they come to my clinic maybe just to work up for any underlying whatever mitochondrial problem or something like that. I mean, oftentimes, even with those who develop a couple more rhabdomyolysis, their mitochondrial function is normal, their muscles look normal, EMG, muscle biopsy, all normal. However, I just wonder, like with that lack of circulation, they may be prone to develop rhabdomyolysis. Prone to develop that. I'm not sure. There's no study that kind of looked at the incidence of rhabdomyolysis in this population when they exercise. I'm not sure about that, but otherwise, physiologically, their muscles are completely normal.
Do they complain of stiffness?
To be honest, I've never really asked that, so I can't really tell. Can't really think about that.
Speak to why a couple of the demographic mechanisms are in place. So, for example, why do you suspect more female, and why do you suspect onset at late teens, early 20s?
So again, nobody has any evidence at this point. It's just a speculation and theories and everything. So I'm going to tell you a couple of kind of theories that some people have actually raised before. So like I said, this is probably just again, effective hypovolemia, meaning without having actual volemia, meaning their blood volumes are normal, but they're not regulating the blood volume, right, up and down against the gravity, because their nerve is not regulating it. But anatomically speaking, men and women, a woman has a lot of gynecological organs. They can pull the blood, and they're more prone to kind of, so in female, especially with the menstrual cycle, when they lose blood and everything, they can actually kind of keep a lot of blood volume in their gynecological organs. They can actually worsen their symptoms or predispose this kind of problem. I think that's actually most probably prevalent kind of theories behind why women have more of this kind of problem than men. But is there any hormonal problem specific? I'm not sure about that. People go, yeah.
You mentioned that oftentimes this is the fifth or sixth different provider that a patient has seen, and it's not uncommon in psychology that we also see patients who've seen all different specialists and they can't quite figure out what's wrong with them.
Right.
Then they send to psychology.
Right.
So are there things that we should be really listening for if folks have not yet seen you or in the clinic about training symptoms, and what would be an appropriate referral for you?
Yeah, actually that's a great question, because I talked to a lot of psychologists and psychiatrists, and when I say they have a POTS, they're so excited, because as a psychologist, psychiatrist, they feel like these are a little bit different population than their typical depression and anxiety patients. And these patients, I guess, if they actually have an orthostatic intolerance or palpitation, I think that's one of the most common symptoms. And also because POTS is actually more common statistically, there's a probably good chance that it could be actually POTS too. I think especially palpitation or orthostatic intolerance are the ones that you can probably ask in addition to other things that you ask. If they have a severe GI problem, that's more suggestive of kind of more physiological basis of the problem, that could be also the problem too. But again, I think they look a little different in a sense that they're very debilitated. I mean, it's just very difficult. Again, like when I compare with other neuromuscular diseases like ALS even, they are just completely debilitated. They just can't get out of the house. And I think that's actually one of the things that I look at most, but just symptomatically, palpitation, orthostatic intolerance, fainting, passing out, those are probably more telltale signs of POTS for otherwise healthy person. Any other questions? All right, well, you know how to reach me, right? So thank you very much for the talk.